Good evening, everyone. My name is Abiola Adewusi, and welcome to another edition of AFRH webinar. Today's topic is going to be adenomyosis, endometrioma, and endometriosis. Are there any relationship? It's going to be a very interesting topic. Co-moderating with me today is Mrs. Inipi Uja Samuel. She's going to join me today in hosting today's webinar. Today's webinar is going to be presented by our very own Dr. Kingsley Agholor. And of course, we're all aware of these conditions that occur giving similar symptoms, and it's still being researched and understood in the space of ART. Understanding more about these indications will help us to improve in diagnosing and even preferring treatment options for affected women. So we're going to have Dr. Agholor do justice to this topic today. But before I move forward, I would like my co-host to do a brief housekeeping introduction before we start. Over to you, Inipi.
Okay, I'd like to welcome everyone to our exciting AFRH bi-weekly webinar series, which is actually dedicated to exploring the fascinating and critical field of reproduction. As we all know, the AFRH conference is fast approaching, and the good news is abstract submission deadline for the 15th AFRH Annual International Conference has been extended to Friday, August 15th, 2025. Dear delegates, you are invited to seize this opportunity to present your research. Submit your abstract today for a chance to win 100,000 Naira for the best embryology abstract. The conference theme is New Frontiers in ART, the roadmap to the future. Kindly check the flyer. The link provided will give you more details. And of course, the conference details still remains September 24th to 26th, 2025. And the location is Lagos Oriental Hotel, Victoria Island, Lagos. Now, the conference registration and payment validates consideration of call for abstract submission. And take this advantage of the extension and submit your abstract today. Please note that no further extension will be granted after August 15th, 2025. Kindly follow AFRH on all our social media handles as displayed on the screen. If you have questions during the sessions, drop them in the Q&A box. We will address them after the discussion segments. This session is being recorded and will be available for playback after the event on our AFRH website. Over to you, Mrs. Adewusi.
Thank you so much for that detailed information. I hope that by the end of this brief, we'll have a lot more discussions to have. I'm going to quickly introduce Dr. Agholor before he starts his presentation. Dr. Kingsley Agholor is a consultant obstetrician and gynecologist, sonologist, and endoscopic surgeon with Central Hospital, Warri, Nigeria, where he worked as a former chief medical director of the hospital. He is a reviewer for original research articles with international conference presentation in the field of reproductive medicine. One of his papers, Patterns of Chlamydial Serology in Patients Receiving Infertility Treatment with In Vitro Fertilization in Benin City, won the prestigious Majakodomi Prize at the 46th Scientific Conference of the Society of Gynecology and Obstetrics of Nigeria, SOGON. Dr. Agholor, who is a fellow of both the West African College of Surgeons and the National Postgraduate Medical College of Nigeria, has now focused his practice as a fertility specialist following the award of Master of Science in Reproductive Health certification in Sexual and Reproductive Health and Research at the Geneva Foundation for Medical Education and Research. He which is enabled by Society Cooperative Medical de Below Scholarship in the Canon of Geneva, participating in the global consultation on World Health Organization infertility guidelines and training in assisted reproductive technology at the Center of Reproductive Medicine and at the Free University of Brussels. He also received training in hysteroscopy at the European Academy for Gynecological Surgery, Leuven, Belgium, as well as training in laparoscopic surgery at Eckhard University, Strasbourg, France. He is an awardee of the highly regarded International Ovarian Tumor Analysis Certification in Gynecologic ultrasonography at Skåne University Hospital, Malmö, Sweden, one of the only two Nigerian with the award, where he also received training in advanced gynecological ultrasound. He is a member of the 3D ultrasound working group of the International Society of Ultrasound in Obstetrics and Gynecology, ISWAG, and Dr. Agholor organizes an annual gynecological ultrasound training course in Nigeria in conjunction with the Unique Specialist Imaging, Canberra, Australia. He practices assisted reproduction, IVF, at Coastal Specialist Hospital, Warri, Delta State. For the record, I'm one of his students. I go for training every year. Thank you very much, Dr. Agholor. You're welcome. Over to you, sir.
Thank you. Thank you, Abhijit. So let me share my slide. This one. Thank you. Thank you.
We can see your slide, sir.
Good evening, senior colleagues and colleagues. I thank the organizers for inviting me to share knowledge on such a captivating topic. I'm also grateful for the very warm introduction. The organizers, AFRH, invited me to discuss adenomyosis and endometriosis. They requested me to explore the diagnosis and classification of these conditions while also discussing what constitutes best practices. I'm also to identify controversies and to include all types of endometriomas in the conversation. Of course, the conversation will be incomplete.
Dr. Agholor, can you hear me?
I can hear you very well.
Agholor, yeah, your connection is breaking, so it's making your audio cease.
We're working on it here. Let's see what it is.
Okay, we can hear you now. Maybe just increase your audio a little bit so you can be more audible. Your screen is gone to. Okay, now you're sharing the.
Can you hear me now? Is it better now?
Screen. Okay.
Is it better now?
Please go ahead.
Okay, great. So I already thanked you for inviting me and giving me the opportunity to share knowledge on the subject. I stated that you have asked me to explore the diagnosis and classification of the condition and to also to discuss what constitutes best practices. You have asked me to identify controversies, and then I'm also to include all types of endometriomas in the conversation. And I also stated that the conversation will be incomplete without a discussion on the impact of these conditions on fertility. When I said the literature while preparing for this presentation, I found that the best way to overcome such a Herculean task was to establish whether a relationship exists between the two enigmatic diseases, endometriosis and adenomyosis and to see whether there's a link with the endometrioma that lies in between. This editorial, published in 2018, suggested that conclusive data on the association is scant, despite the vast amount of literature that is available. But from what prism are they looking at the glass? Scant means empty. From what prism are you listening to this conversation looking at the glass? Scanty too? Or is it half empty? Or half full, depending on your perspective? Or is it full? You're thinking about it, right? Well, at the end of this presentation, you will see how ultrasound has contributed to the debate and provided data indicating a conclusive relationship. I disclose who I am, that I'm a GE Healthcare key opinion leader in gynae ultrasound, and that I do receive fees from GE to give lectures on gynae ultrasound. At the end of this presentation, I believe that, could you minimize this for me? Sorry, I just want to minimize this. Yes, thank you. At the end of this presentation, I believe that you will learn that real-time dynamic transvaginal ultrasound examination is the first test in the diagnosis of both adenomyosis and endometriosis. This is important, especially as diagnosis is therapy. Again, you will see that high-end ultrasound and high-level skills are required to optimize diagnostic accuracy, but these can easily be acquired. Again, you will understand the typical ultrasound features of adenomyosis, endometriosis, and endometrioma, while we aim to establish whether a relationship exists between the conditions, and then we are certain whether they occur simultaneously. Lastly, you will understand the proposed, recommended, and evidence-based diagnostic and treatment algorithm for this complex condition. The aim, of course, is to improve the reproductive health outcome of affected women. So, what is adenomyosis? There is international agreement that the best definition of adenomyosis is the one offered by Baird in this landmark paper, The Elusive Adenomyosis of the Uterus Revisited, published in 1972, wherein he stated, adenomyosis is the benign invasion of the endometrium into the myometrium, producing a diffusely enlarged uterus which microscopically exhibits ectopic, non-neoplastic endometrial glands and stroma, surrounded by the hypertrophic and hyperplastic myometrium. The keywords are, the disease is benign. It produces a diffusely enlarged uterus which arises from ectopic endometrial glands and stroma. So, how ectopic are these lesions? Histologically, we learn that it is the invasion into the myometrium of ectopic endometrial glands and stroma, at least more deeper than 2.5 mm from the endometrial basal layer. This has been the gold standard for the diagnosis of adenomyosis for many years. But this gold standard is now questioned by imaging techniques. Adenomyosis was first recognized with MRI in this paper by Togashi in 1988. Later, with transvaginal ultrasound in this work by Luigi Fedele in 1992. These imaging techniques have improved the diagnosis and led to the recognition of adenomyosis without the need to depend on histology. Indeed, when the results of transvaginal scan and MRI were compared with the histopathological findings, these imaging techniques were found to correlate well with histological examination of a hysterectomy specimen. In simple terms, both histology, MRI, and TVS are comparable in the diagnosis of adenomyosis. None is superior to the other, as they all perform the same. So the diagnosis has moved from histology as the gold standard for diagnosis to now a clinical entity, leading these authors in this meta-analysis and systematic review to recommend that transvaginal ultrasound should be the first line in the diagnosis, first-line diagnostic method for adenomyosis, because ultrasound is widely available, therefore very easily accessible, and of course better tolerated by patients and cheaper than MRI. So MRI should serve as the second line option only if transvaginal scan is inconclusive. But such inconclusive report will be few and far between if TVS is performed by dedicated sonographers or imagers who can recognize the distinct pattern in the diagnosis, distinct ultrasound pattern in the diagnosis of adenomyosis. So let us look at some case examples of inconclusive reports, like this one, brought to us by this 28-year-old nulliparous lady. She presented to us for infertility care after 2 years of trying to conceive. She also complained of severe dysmenorrhea and deep dyspareunia. She came with 2 ultrasound reports. This one, the first one, was performed on the 10th of August, 2021. See how time flies. So according to the patient, the imager performed the scan with a trans-abdominal scan first, and so he reported the liver, the gallbladder, the kidney, the pancreas, and the spleen, and then the bowel, before using the transvaginal probe to view the uterus, which he described as normal in size, antiverted, and non-gravid. Great. But what does normal in size mean? The actual measurement ought to have been documented or reported so that we are sure that what is normal in size is not the subjective judgment of the imager. The importance of this we learn from Saken and Abu Ahmed, who showed that global uterine enlargement that is generally up to 12 cm in uterine length and that is not explained by the presence of fibroid is a characteristic finding in adenomyosis. So, well, the final impression in the report said that the features are in keeping with tiny uterine fibroids. So as is common in Nigeria, women generally drive their own treatment in the face of persisting symptoms. So she presented elsewhere for another scan. And then this scan, second one, performed on the 27th of August, was about 17 days from the first one. This time using only the trans-abdominal probe. We see that the uterus is suddenly bulky and that the uterine length measurement here approaches about 11 centimeters. Importantly, the imager reported that there are ill-defined echogenic areas involving the posterior and fundal myometrial regions. This is a term for describing adenomyosis. In fact, the imager actually recognized acknowledged the association of this term with adenomyosis in his report, where he stated query background adenomyosis. And so the patient was advised to seek confirmation of the condition with transvaginal scan. Why transvaginal scan? Because it is impossible to get good image resolution with trans-abdominal scan to enable a reliable distinction between adenomyosis and uterine fibroids. So she presented to us and I scanned her using the transvaginal probe. And what did I see? I found that she had a bulky uterus measuring 12.1 by 8.5 by 7.7. Remember the advice by Saka and Abu Ahmed that a uterine length of greater than 12 cm, the implications of that. Okay, so I scanned further therefore, and I saw that there was a global fundal enlargement. I also saw that there were myometrial cysts, there were shadows, and there were loss of endometrial myometrial junction, and there was echogenic island. All sonographic terms for describing adenomyosis. Not to forget the typical spherical shape of the uterus, as you see in this image. The spherical shape has been previously described by the Musa group as a feature of adenomyosis. Language really matters. And so this consensus statement has given us both a language to describe the sonography features of adenomyosis and a system to recognize these features using ultrasound. Further refinement of definition, again by the Musa group, has led to the recognition of these features as direct and indirect. Direct features signify the presence of ectopic endometrium. And you see this on ultrasound as myometrial cyst here, shown here, hyperechogenic islands, and then subendometrial lines and boards. And then the indirect features, they are indicators, the secondary to the presence of ectopic endometrium. So we see them on ultrasound, for example, as asymmetrical thickening, where lesion distribution is localized to one myometrial wall, in this case, the posterior wall. And then, or as globular uterus, where lesion distribution is uniform. You can also see them as fan-shaped shadowing, translesional vascularity, or the junctional zone can be irregular or interrupted. And so when you put your probe and you scan, the first thing you see are the indirect features, like shown in this image A, asymmetrical thickening of the posterior wall, you see, and then in image B as shadows. And so when you see these things, you ask yourself, why do I see these things? Then you scan further, and then you can see the echogenic islands here, and you can see the myometrial cyst here, which are the direct features. Let me show you some video examples, because we learn from Bloom and Dohom that the ultrasound features of adenomyosis are best demonstrated using video clips. So look at this video, and you see the fundal enlargement, very obvious. Asymmetry of the anterior and posterior myometrial wall, very obvious. And then you see the shadows, very obvious. And then you look further, and you see the myometrial cyst here, you see the echogenic islands here, and if you look deep, you could actually see the subendometrial lines and board. And then if you switch on your Doppler, you can also see the translesional vascularity shown here. And then if you, again, look at this image, this is a video, let me play the video, you see a maze of echogenic island. And if you look deeper, you will see subendometrial lines and boards. The subendometrial lines and boards are continuous with the endometrium. That is the difference between them and the echogenic islands. Now, it is important to know them because there's good and consistent evidence to show that pregnancy implantation rate is poor, ongoing pregnancy rate is poor, and miscarriages are high in the presence of subendometrial lines and boards. So it's important to know that they are there. But to be honest, sometimes they are difficult to find, as you see here. So you may, more often than not, require a 3D rendering to be able to see them well. In truth, the junctional zone is best visualized using 3D. So you need a high-end machine, and you need some level of expertise. And this is how they appear on 3D. You see a normal endometrium sandwiched by adenomyosis on either side. What do you see? If you look, you see a clear endometrial myometrial junction. See it here, very clear. And then if you look at image A, you see infiltration of the junctional zone by adenomyotic tissues. You see there are perpendicular projections from the endometrium into the inner myometrium. You see it here also. Now, it is important that we know and recognize this when we scan. Why? Let's see why. These are all the ultrasound features that we have discussed now of adenomyosis, listed here in this paper by the Djokovic. And they performed the logistic regression of these ultrasound features of adenomyosis against the probability of clinical pregnancy. And they found that irregular endometrial myometrial junction as a single feature is associated with poor reproductive outcome. Look at it there. It's an all or none feature, meaning that in the presence of distortion of the junctional zone, implantation rate is poor, clinical pregnancy rate is poor, and miscarriage rate is high. It is therefore important to recognize it as we have just done. But what will you do with the information? Well, evidence suggests that in the presence of moderate adenomyosis or mild adenomyosis with infiltration of the junctional zone, patients will benefit from the use of gonadotropin releasing hormone analog pre-treatment before IVF and embryo transfer. This therapy is believed to produce a window of time with implantation because they decrease the size of the adenomyotic lesion and create a demarcation in the junctional zone to allow implantation. A 3 to 6 months pre-treatment is generally recommended. So that's what we should do. Now we see Stefan Gott, Rudy Campo, and Brossens, giants of hysteroscopy, advise that we should perform a 3D ultrasound scan routinely to pay special attention to the junctional zone so we can identify adenomyotic lesions. And they advise that we should proceed immediately to hysteroscopy to excise these adenomyotic lesions. Indeed, we learn from the highly regarded Mowat that although medical therapy is good, alone it has a short period of conception. But when combined with surgery like hysteroscopy, it offers a better pregnancy rate and a more sustained ability to conceive. So this is how adenomyosis may appear at hysteroscopy. You see irregular endometrial mucosa. You also see strawberry pattern, sheets of hemorrhage with a central white spot. You see hypervascularization of the fundus, and then you see small hemorrhagic foci, which can either appear as chocolate brown spot or dark bluish features on the fundus. And so when we scanned this patient and we saw this infiltration of the junctional zone by adenomyosis, we decided to proceed to hysteroscopy. And at hysteroscopy, what did we find? We found, look, see these hemorrhagic spots like strawberry signs there. Then you see this bluish tinge here, just here. So we decided to explore, just as we are doing now. And yes, did you see the chocolate fluid coming out of the hemorrhagic cyst that is locking behind? So this hysteroscopic is therefore both diagnostic and therapeutic, especially when you see subendometrial lines and boards at 3D ultrasound. Is there a place for surgery for adenomyosis? Yes, there is a place for surgery beyond hysteroscopy. Debulking surgery, as it is called. Laparotomy rather, is favored over laparoscopy because of the increased risk of uterine rupture following laparoscopic repair. So who should have surgery? Surgery is recommended in those with severe disease, in those with diffuse adenomyosis with dysmenorrhea and hypermenorrhea, presence of adenomyoma with symptoms, and those with repeated IVF failure and recurrent pregnancy loss. Is there a system for determining which disease is severe? Well, there are a number of classification and scoring systems, and there's no agreement on which is best. But this sonographic classification and reporting system shows us that adenomyosis can be described as focal, that is adenomyoma, or mistype in the presence of focal and diffuse lesions, or diffuse where it is all over. Again, using the system, we can describe adenomyosis as mild, where less than 25% of the myometrium is involved, or moderate, where between 25 to 50% of the myometrium is involved, or severe, where greater than 50% of the myometrium is involved in disease. And that what we just did, and we use the information to decide which patient should have surgery. What type of surgery should they have? For many years, gynecologists have managed adenomyosis with hysterectomy or wedge resection where fertility is desired. You know, many times your preoperative assessment, diagnosis of uterine fibroid is not what you see at surgery. And the consultant tweeted the senior registrar, you know, this is adenomyosis and it cannot be removed at surgery. Yeah, that was until Hisa Usada showed clearly how adenomyosis can be removed to conserve the uterus of future pregnancy. The procedure, now described as Usada procedure, named after the legendary surgeon. How is it done? Time will not allow us to discuss the procedure in detail, so a pictorial will suffice. This is what you see at surgery, a globular uterus with no palpable lesion or mass when you palpate it. Now, bisect the uterus in two halves, and this is what you see. And then when you examine the bisected uterus, you will see the asymmetry in the anterior and posterior myometrial wall, as you are seeing there. In particular, you will see a cheesy appearance of the myometrium. This is adenomyosis. This is what you want to debug. And then when you complete your debugging or enucleation, this is how the uterus will appear. And when you complete repair, this is what you see. To be honest, repair is tricky, and there are reports of severe hemorrhage and leading to hysterectomy following repair. So some training is necessary to be able to do this. Now, we have shown that uterine sparing operative treatment for adenomyosis is feasible, but is it efficacious? Evidence from this systematic review shows us that, yes, it is efficacious. After complete excision, dysmenorrhea is reduced, menorrhagia is controlled, and pregnancy rate is as high as 60%. It is efficacious. Regarding pretreatment strategies for adenomyosis-associated infertility, we have talked about surgery. We have talked about medical treatment. In particular, we talked about the need to combine gonadotropin-releasing hormone analogs and hysteroscopy. This also applies to open surgery. So we can apply gonadotropin-releasing hormone analogs for 3 cycles after open surgery for adenomyosis. That's what the evidence now says. Again, there's emerging evidence now that levonorgestrel intrauterine system can be used as an alternative for gonadotropin-releasing analog. It is used. Very important, because patients complain of harrowing experience with the use of gonadotropin-releasing hormone analogs. And the price of those medications today are becoming unbearable. So, I mean, if you go to the market tomorrow and you say there's no Mirena, know that there are a bottle of them. Now, regarding HIFU, there is no consensus on the indication for using HIFU ablation to improve fertility, because evidence for its use is limited. However, there's evidence to show that it is useful, especially as the therapy allows a focal targeted application of the ablation. So we have shown that treating adenomyosis improves fertility outcome. What if we leave the adenomyosis in situ and proceed to IVF? So let's see what we learn from this paper. In the absence of any ultrasound feature of adenomyosis, pregnancy rate following IVF is as high as 48%. In the presence of 7 ultrasound features which you have identified of adenomyosis, pregnancy rate is as low as 2%. In practical terms, when the uterus contains 4 or more ultrasonographic features of adenomyosis, there is a strong likelihood that IVF outcome will be poor, 15% and under. Therefore, we need to recognize this and pursue adenomyosis. Now, let us move on to ultrasound. What do you see? What do you see? Let us zoom the image and then talk about what you see again. What do you see? Yes, somebody typed in question mark endometrium. Yeah, that's correct. Question mark endometrium. Yes. So is a very important way of recognizing adenomyosis. We learned that from Nadine Dinato, the question mark form of the uterus. Actually, it's a thickening of the myometrium. Here, the uterus is, you see, the uterus is, the fundus is directed towards the pelvis, and the cervix directed anteriorly towards the bladder. That's quite important. And so we capture the same image here. The uterus is described, the orientation here, as anteverted but retroflexed. Anteverted but retroflexed. Why is the uterus in this orientation? Because it is pulled back by adhesion. why would we have adhesions in a patient who has not had surgery? Well, there is an association between adenomyosis and endometriosis, which has been documented now. And we see in this paper that the prevalence of adenomyosis in women undergoing surgery for endometriosis is as high as 22%. And when these women were scanned, we found 3 or more sonographic features of adenomyosis. And we see it here ourselves. We captured it here in Costa Clinic. Look at this endometrium, question mark endometrium. See that? So rotate your probe transversely, and then you picture the endometrioma. Did you see that? It's the endometrium. That's it. The endometrioma, and then it's actually bilateral endometrioma. That's it. See the endometrioma? So there's an association. Charles Chaplin was one of the earliest persons to note that ovarian endometrioma is a marker for deep endometriosis. We've seen question mark endometrium. We've seen bilateral endometrioma associated with question mark endometrium. Nadine Dinatu has shown us that there's an association between adenomyosis and endometriosis. We now see that ovarian endometrioma is a marker for deep endometriosis, prompting admonitions like this one, that for gynecologists, please stop booking patients for cystectomy when there is an endometrium, because there is almost always so much more. And then help us tell the patients that if you have an endometrioma, be wary of scheduling for cystectomy with a non-laparoscopic gynecologist. Why? There is almost always so much more. So what is recommended now? In the face of accumulating evidence that surgery impacts negatively on ovarian reserve, which is already low in the patient with endometriosis, nowadays, surgery is no longer recommended in the first instance in women for whom endometrioma is coincidentally detected on transvaginal scan. What is recommended? Conservative approaches are now adopted with medical treatment using oral contraceptive pills and progestins at first line to relieve pain and dysmenorrhea, no matter the size of the cyst. And for cystic lesions that are less than 4 cm in the absence of symptom, expectant management is suggested. So the surgeon should err on the side of expectant management or conservative management with medications. And the image, this image, you see that of a patient who had small endometrioma, as you see there, receiving ovarian stimulation for IVF. She did not have. So when is surgery indicated? When pain overwhelms medical treatment. Then when fertility is desired, because these medications that we are talking about cannot be used in a woman who is actively seeking to get pregnant. Again, consider surgery if you scan and you see low-lying adherent ovaries or kissing ovaries, because assessing these ovaries during oocyte pickup might not be so easy. Strongly consider surgery if you find the endometrioma with ultrasound features suggestive of malignancy. The image here shows us how normal features look like. So how does an endometrioma look like? Number one, diagnosis typically relies on ultrasound images like this one we just seen here, which the IOTA has described as unilocular cyst, regular antique walls. The cyst content is ground glass, usually homogeneous, of old blood. And then you may notice internal wall nodularity, which are actually fibrin clots, like this one here, as you see here, this one. And then when you switch on your Doppler, the cyst wall is completely avascular. So isolated ovarian endometrioma is rare. That is the reality. More often than not, they are indicators of pelvic endometriosis. And from Katrina Zakutus, we learn that left ovarian endometrioma is associated with rectal deep endometriosis. And of course, left uterosacral ligament localization of disease. Bilateral endometriomas, which we call kissing ovaries, sometimes when they are close together, adherent to each other, kissing ovaries, are associated with adhesions and patch of Douglas ovaries. There is no correlation between the endometrioma size and deep endometriosis. Let's be clear. The size of the endometrioma does not matter. So do not see an endometrioma and say this endometrioma is less than 5 cm. No, it doesn't matter. No. A smaller endometrioma may be associated with more severe disease. So when you see endometrioma, search for endometriosis implants in the rectum, in the uterosacral ligament, and search for concomitant adhesion. This is critical in the patient desiring fertility. And we see it here in this image. See the endometrioma, left endometrioma, attached to the back of the uterus. See the point of adhesion there, completely adhered. Again, we see this bilateral endometrioma, they are kissing ovaries, completely adhered to each other, and obliterating the patch of Douglas. We learn that kissing ovaries are a sonographic sign of moderate to severe endometriosis. And this is how they appear at laparoscopy. Just some music for you. So we see that they are completely adhered to each other, adhered to the back of the uterus, and then the endometriosis is locking behind, causing severe adhesion. So the more you look, the more you see. And so you see this image with multiple cystic lesion, ground glass, anechoic, and low-level echogenicity. Typically, when you see ground glass and you see adhesion, that is endometriosis. The other cystic lesions are more often than not atypical endometrioma. But many times your sonographer will see an image like this and report it as complex mass. Please avoid such terminology. Complexity is a limitation of the capacity of the imager to make a proper diagnosis, because the eye cannot see what the mind does not know. We already said that from iota, that the typical endometrioma is a unilocular cyst, ground glass echogenicity, with or without internal wall nodularity, and is avascular. A typical endometrioma, on the other hand, contains fluid, cyst fluid that is not ground glass, is bi or multilocular, contains retracted blood clot or solid component, may be calcified, and be completely atypical, such that in pregnancy they contain vascularized papillary projections. But more often than not, this diagnosis is usually histological. And we see it here in this image. Is it a dermoid cyst or an endometrioma? You see the heterogeneity. I said that endometrioma is homogeneous, remember? And then you see the heterogeneity in this cyst now. And then you see the echogenic white lines and dots, and you see that. So one of our team members said this is a dermoid cyst. The histology showed us that it was an endometrioma. So it's a typical endometrioma, atypical endometrioma. Again, we see this. Left ovary was an endometrioma, and then the right ovary was a cyst adenoma, an echoic cystic lesion. But you see they are kissing ovaries and adherent to the back of the uterus. Well, histology showed us that it was an atypical endometrioma. And then you look at this image A. When I scanned this patient, the cyst content was, streaming, low-level echogenicity. And then you see this white ball, calcified lesion that looked like the white ball in dermoid cyst. But clearly, the cyst content was low-level echogenicity. We're not sure what it was. The histology showed us it was an endometrioma. And then, of course, you have these multiple lesions here. Let's be clear. Beyond the iota, some other classifications say that An endometrioma has 1 to 4 locus. So this could be typical for those who have 1 to 4 locus, and it's atypical to the aorta. So we have said that ovarian endometrioma is rarely isolated. We have said that it's a marker of deep endometriosis. So what is deep endometriosis? When endometriotic lesions extend far more than 5 millimeters beneath the peritoneum, causing cyclical bleeding and inflammation and fibrosis. And then you end up with irregular hypoechoic solid nodules that are usually avascular and are surrounded by partly echogenic fibrosis. This is what we are talking about. This is what we are talking about. You see the solid dark nodules here. This is your endometriotic implant. And then surrounding it is the fibrosis that we talk. Let me show you some examples. Now, look at this image that we find here. Let's make sense of it. Yeah, the uterus is here, and then the torus uterinus, which is the back of the cervix, and then, of course, the posterior wall. Now, look at this. This is an endometriotic implant. Look at the fibrosis surrounding it. This is deep endometriosis of the uterosacral ligament. Look at this one. This is in the muscularis propria, the bowel nodule of endometriosis. And then you see these dark lines and the fibrosis surrounding it. This is adhesions of the bowel to the uterus. With training and learning, you'll be able to pick up all of these things on ultrasound. Why is deep endometriosis important? Because of the 3 subtypes of endometriosis, it is the one that requires the most advanced laparoscopy. The need for multidisciplinary approach requiring the colorectal surgeon and the urologist time to time. So you need to identify it before going to surgery. And these landmark idea consensus papers has provided us an algorithm or a systematic approach to the sonographic evaluation of the pelvis in women with suspected endometriosis. How is it done? 4 steps, 4 sonographic steps have been described. We begin with the routine evaluation of the uterus and adnexal, which you all are familiar with. And then we can then look at the sonographic signs of adenomyosis, which we have just discussed. And then we look at the search for the presence or absence of endometrioma, which we have also discussed. And then you follow the steps and finally end up recognizing deep endometriotic nodules. So we have said there is adenomyosis, there is endometrioma, and there is deep nodule of endometriosis. So there's a linkage. There's a linkage. Yeah. And efforts outside of ultrasound has actually shown that there's a linkage. And so we see here that endometriosis and adenomyosis are actually sister entities. In fact, it has been said there are these different phenotypes of the same disease. And if you look at it, the definition is actually the same. It is the presence of ectopic endometrial-like tissue. And furthermore, we've looked at, it's been proposed that adenomyosis externa arises from pelvic endometriosis, and focal adenomyosis of the outer myometrium arises from bladder and rectal adenomyosis. So there's a linkage. And then if you look at here, look at this clinical similarity here. Although there's an attempt, now you look at it, say that this peaks in 20s and 30s, and then 40s and 50s, and that is adenomyosis, a disease following pregnancy. There's good evidence now that adolescents, nulliparous adolescents, can present with very severe forms of adenomyosis. So this is being questioned, whether adenomyosis is related to pregnancy or otherwise. But importantly, there is clinical similarity between the 2 diseases. Look at it here. Dysmenorrhea, heavy menstrual bleeding, infertility. So we see that there's similarity. And this single cell analysis of endometriosis and adenomyosis showed us that they are sister disorders. Yes, but they are not identical. And we see that the mechanism of action is actually different. beyond the mechanism of action, they are almost the same, apart from this comment on multi-gravity, which we have just told you is now being contested. And again, look at the symptomatology. The symptomatology again is the same. This paper has suggested now that we should start using the symptoms as a diagnostic tool. And we see here symptoms as a diagnostic tool for endometriosis. We see here symptoms as a diagnostic tool for adenomyosis. Importantly, for hysteroscopic surgeons, hysteroscopy is now a diagnostic tool for adenomyosis. It's there. Now, this state-of-the-art paper suggested or has proposed that we should use symptoms as a tool for earlier diagnosis of disease, because of course the similarity in symptoms. Although developed originally for endometriosis, it can be adapted to adenomyosis because the symptomatology is the same. And so when we take history from the patient and we elicit the symptoms that we have just enumerated, then our antenna should rise and have a clinical suspicion of adenomyosis or endometriosis. And then when we do a bimanual examination and we palpate deep nodules of endometriosis, then we should escalate to high suspicion. And then if we do a speculum exam and we see vaginal nodule of endometriosis, then we have a suspected diagnosis. And if we scan the patient and we see ovarian endometrioma, then the diagnosis has been made. We can then do advanced TVS to assess the severity. And then we can clearly, using this algorithm, reach a clinical diagnosis where we can just offer treatment, leaving laparoscopy for only when surgery is needed. So what is clinical diagnosis? This is where endometriosis is defined as a menstrual cycle-dependent chronic multisystem inflammatory condition that presents with pelvic pain and or infertility. It is believed that if we combine this clinical diagnosis with this linkage that we have shown between adenomyosis and endometriosis, we are likely to improve the diagnosis of these conditions and then reduce the diagnostic delay, which is often quoted to be about 8 years. Because of course, this diagnostic delay arises because of the dependence on surgery for diagnosis. We are moving further and further away from surgery as a diagnostic tool, laparoscopy. Well, for this advice from the Society of Radiologists in Ultrasound, that any single direct imaging observation category A, like endometrioma, for example, should lead to the diagnosis of endometriosis. That's where we are now. Why are we interested in all of this? Because available data show that patients with endometriosis have an increased estimated risk of infertility between 2 to 4 times compared with the general population. This is huge. Again, endometriosis is associated with lower rates, lower oocyte yield, lower implantation rate, and lower pregnancy rate after IVF. This is worse in the presence of other alterations in the reproductive tract, like hydrosalpingo. Again, ovarian reserve is reduced in patients with endometriosis, especially in those with ovarian endometrioma and disease at advanced stage. Again, endometriosis-associated infertility treatment is limited, leaving surgery and IVF as the mainstay of effective therapy. Surgery itself is indicated when pain overwhelms medical treatment. And of course, when fertility maybe is desired. So, when there is visceral obstruction, like ureteric obstruction or bowel obstruction causing dysesthesia, in the presence of hydrosalpingo arising from severe adhesions, you need to start considering surgery. We already talked about how to manage endometriomas prior to ART, all of the advice. And then medically assisted therapy, i.e. IVF, should be considered in asymptomatic patients with long duration of infertility and with decreased ovarian reserve. A patient who has had the previous laparoscopy for endometrioma should not be having it. That said, treatment should be individualized with multidisciplinary approach through shared and informed decision-making process. Central to this is a discussion on the suspected level of impairment, i.e. the stage of the disease. because an unskilled surgeon should not operate a stage 4 disease. Before this international consensus statement, there was no agreement on non-invasive techniques for classifying or scoring endometriosis. This international consensus statement reviewed all the classifying and scoring system and favored the hashtag Enzian classification. This is to ensure that we all speak the same language when talking about endometriosis classes. Therefore, if I say that this is a stage 3 disease, it means a stage 3 disease to you. Such precise classification will help with surgical plan, so you know whether you can operate alone or whether you need to call in a more experienced surgeon. And this is the hashtag Enzian classification, believed to be more accurate in describing the time or duration of surgery, the period of hospital stay, and the probability of complications. Let us reiterate the importance of exhaustive information dissemination and precise consent, because every patient is a different patient. And if surgery, tailor your surgery to meet the need of the patient. Every management to meet the need of the patient. If at surgery, remove what you can. Limit yourself to your surgical skills. Apply good surgical technique. Do not cause more damage than the disease. That said, surgery for endometriosis positively impacts fertility. That is true. In conclusion, we have shown that there's a high association between adenomyosis and endometriosis, that both of them have been described as far back as 1920 by Thomas Cullen, that there are different phenotypes of a single disease. Today, we believe that adenomyosis may be interpreted as a marker for deep endometriosis. I thank you all for listening. Thank you.
Thank you very much for that lucid presentation, Dr. Agholor. I expected nothing but what you have presented. It is very, very detailed, very educative. I felt like I was in school again. I'm actually very proud that I was able to recognize some of the markers for deep endometriosis. So you have made us proud yet again, and I'm sure that we have some questions in the Q&A box. So I'm going to hand over to Inipi to read out whatever questions we have for Dr. Agholor. Thank you.
Thank you, Matt. Thank you, Doctor, for the highly expository presentation. We'd like to encourage everyone to please post questions in the Q&A box so that we can take it and have Dr. Kingsley address the questions, please. Questions?
You might want to check the chart, because I think there are many comments on the chat box. Make sure that there are no questions there, if there is nothing in the Q&A.
Okay, so as it is, there are no questions in the chat box as well.
Okay, so if there are no questions, Dr. Agholor, I actually have a question for you. For the purpose of diagnosing adenomyosis, you indicated that it's recommended by one of the researchers that a 3D ultrasound should be used routinely.
Yes.
How about in the event that a clinician, probably does not have that capacity or the 3D machine to be able to do this routine scan? What will be an alternative to the 3D routine scan to be able to diagnose adenomyosis or endometriosis as it were, especially concern as related to the uterus?
Yes, that is quite, one of my teachers, Terry Vanderbuch, he said that that this is what he said. I'm not the one that said it, you know. So let us be clear. I'm not the one that said it. He's the one that said it. He said that if you are involved in infertility care and you are not doing 3D, then you are pretending to be involved in infertility care. I'm not the one that said it. It's Jerry Vanderbush.
But do you agree though? Do you concur?
No, my opinion is not actually important. What is important is that someone I respect said something like that, and it triggered me to look at the issues a lot. You can imagine now that if you do not do 3D, you are going to miss lines and boards. And so if you miss lines and boards, you take the patient to have IVF. The success rate is about 2%. That's what the evidence said. So it means that the patient will have repeated IVF failures until somebody does 3D and says, oh, wow, look at it. This patient has lines and boards. She should have either Zoladex or she should have hysteroscopy to pick out this. So that's an option. If you cannot do 3D and you suspect a patient has adenomyosis, then follow the advice of Stefan Gotts, Rudy Campo, and then go and do hysteroscopy for the patient. We have seen now that hysteroscopy is a diagnostic tool for adenomyosis. So if you do not have 3D, you may wish to consider hysteroscopy for the patient that you think has adenomyosis because you cannot see it. And saline infusion sonography is not helpful. So it has to be a 3D resolution.
Okay, thank you very much for that question. But you know, in this part of the world, or in this part of, you know, we have a lot of ART specialists that you know, are up and coming, and you know, it'd be nice, I guess, if they don't have that tool to refer, maybe to be able to help the patient if they're not able to do it. But that's a very, very germane message to take home as far as diagnosis, because it's quite a lot, more than we can even imagine. You know, what you don't know, you don't know, but what you know, you find a lot of it. So maybe if we're not equipped to do 3D, we should refer to help the patient in the diagnosis of endometriosis, or if we suspect that that may be what it is, before going through treatment. Thank you very much. Any questions?
Yes, we have questions now. Can I go ahead and read them?
Okay, go ahead, please. Go ahead.
Okay, sir. Ubara is asking, is it possible for a person with endometriosis to become pregnant?
Of course. Yes, it is possible for the patient with endometriosis to become pregnant. But to be honest, pregnancy is not easy. So yes, infertility is a challenge, and they can become pregnant. They can become pregnant spontaneously, but that is few and far between. They are more likely to get pregnant with active care because, you know, the pain of the menses is so terrible that they have to have analgesics. And the analgesics that they are likely to have are anti-pregnancy. If they have simple things like non-steroidal anti-inflammatory agents, that is anti-ovulatory. If they have progesterone, again, we are out. If they have OCP, we're out. If they have Zoladex, we're out. So they can get pregnant, but they need the care of a gynecologist. That is true.
Thank you, sir. An anonymous attendee is asking, is adenomyosis related to pregnancy with research?
I don't understand that.
Is adenomyosis related to pregnancy with research? Okay, that question. Please, you need to rephrase because the question is not coming out.
Say that adenomyosis has a negative impact on fertility.
Okay, maybe, okay.
Yeah, and that pregnancy outcomes in patients with adenomyosis is poor. There's increased risk of, there's increased poor obstetric outcome, increased preterm deliveries, preterm loss, and high miscarriage rates. So it's not a good thing to have.
Okay, so Chimeze is asking, what's the rationale behind the use of LNG-IUS in the management of adenomyosis?
It's a progesterone, it's a progestogen. So what it does is not so clear because not all women will respond positively to progesterone. And in fact, there is if you look at that paper on the cell analysis, it says that there is a response to progesterone is questionable with adenomyosis. But we know that if you put in Mirena, levonorgestrel reducing system in the uterus of patient with endometriosis, it does not stop progression of disease, but it controls the pain.
Okay. Okay, so Linda is saying, thank you, sir, for the presentation. In the conservative management of endometrioma, how long do we give generate anti-analog, and do we need to monitor size regression using TVS? Thank you, as transvaginal screening.
As is known generally,
Yes.
you cannot use gonadotropin reducing hormone analogs for more than 6 months consecutively, except you are going to add back therapy. So that's what the rule is. Do you need to monitor to see regression? The truth is that when you stop the GnRH, the disease comes back. So what are you monitoring?
Sure. Okay, sir, thank you. Ngozi is asking, she had adenomyosis and was preparing for IVF. The doctor treated her with Zoladic injection. After the 3 months treatment, yet the IVF process failed at the end. Why?
I do not know, but the thing is, what is the stage of the disease? You know, just as I was preparing for this presentation, one of my doctors called me that there was a patient that we had. She was our patient in 2023. And she had adenomyosis surgery, started procedure with us. And then she vanished. And then represented in 2025, now with severe adenomyosis again. And she declined surgery. And she said she wanted to have the Zolades. So she had the Zolades, 3 courses. We reassessed her and found out that it's back to square zero, no advantage. So my doctor called me that, Chief, the husband is a soldier, he's a military man. And I'm afraid to tell him that they should have surgery again because I've looked at it. This is what she needs to do. Because even if she takes Zolades for another 3 months, it's not going to change the picture. I said, tell him that surgery is the best option. And he told him, he called me back, Chief, you're correct. The man said, when are we going to do the surgery? That's the point, that we need to determine the severity of disease. We showed where surgery is necessary. Severe disease, diffuse adenomyosis, adenomyoma with symptom. What is the classification of the disease for this lady who wrote this thing here? So the classification of her disease will determine what the best treatment option is. It's not her choice. It's not for her to say, I don't want surgery. I cannot have surgery. Therefore, we'll just be petting the matter. The doctor should be bold enough to tell the patient, look, surgery is what you need. If you don't need surgery, then you can go to another clinician to continue your care. You don't have to be with him. Because he's going to be recording that failure of IVF now against that fellow. And probably if he sees me, he's going to be cursing that guy. He's just doing that. Meanwhile, the young man did his best.
Okay, thank you, sir. Okay, so Ubara is asking again, is there any research that has proven that contraceptives can reduce the growth of endometriosis or fibroids?
We said gonadotropin, what's called levonorgestrel intrauterine systems. That's a contraceptive. So yes, it's a tool for treatment. Yes, and interestingly, progestins, they are contraceptives, are useful as a tool. It's the cheapest. The only challenge, Depo-Provera, the only challenge is, the negative impact on fertility. But if fertility is not desired, that's the cheapest tool for the treatment of adenomyosis and even endometriosis, adenomyosis in particular. The cheapest tool because it's so cheap, just an injection every 3 months, and nice.
Okay, thank you, sir. Bright is asking, please, what is your take on fertility preservation in young girls with endometrioma?
Yeah, to be honest with you, that is what should be done. You know, I have a young lady, and she's a doctor, you know, and she read a lot. You know, I scanned her and confirmed that she has endometriosis. And, you know, she asked me the question, do you think I should have, you know, my eggs frozen or tissue stored to help with future fertility? Because it's just a recent diagnosis. And you know, as she was saying that, her mother, who is a senior doctor, said, no, it's not, it never reached like that. It's not that bad, you know. So, and I didn't know how to enter the conversation. So I said, well, I think you should think about it. Really, I tried to call the young lady separately and the mother separately to advise them that that's the best thing to do, because ovarian reserve is poor. We said it in our presentation. We just did egg collection for a lady with endometriosis, 34-year-old lady, that I had advised. Her ovarian reserve was seemingly good. And I said, look, the ovarian reserve will poor, be careful. We got 11 eggs and fertilized them, only 2 fertilized. Where are we going to go with 2 embryos? I do not know. So, but we have to transfer and then hope for the very best. But the truth is that it's an option that should be done very early if the diagnosis was made early. And then, of course, AMA shows that ovarian reserve is still good. It's something that can be done.
Thank you, sir. We have 4 more questions to go. Thank you, sir. Obina is asking, sir, are you saying that ovarian endometrioma should not be approached by laparotomy?
Of course. Why should he do that? Because, you know, there's severe adhesion. You should not approach by laparotomy at all. Approach laparoscopically, gives you better views. You are able to make proper diagnosis. Pick up superficial endometriosis where there, because at open surgery, you cannot see superficial endometriosis. All right. Now, at open surgery, remember, we said that endometrioma is a marker for deep disease. So how are you going to approach the deep disease at open surgery with severe adhesions posteriorly? So let us do what is best, laparoscopy.
Okay, thank you, sir. Mohammed is asking, how do you use GnRH to treat adenomyosis before starting stimulating in IVF?
No. You stimulate the patient, collect the eggs, fertilize with husband sperm, and freeze all. Then you start your levonorgestrel intrauterine system. Is it the levonorgestrel he asked or GnRH? Which one did he ask?
Sorry, sir.
Which one did he ask?
Before starting stimulating, before IVF,
no, is it levonorgestrel or GnRH?
Yes, GnRH.
Okay, yeah, GnRH. So what you do is please don't give GnRH before stimulation, please. Stimulate the patient, collect the eggs, fertilize them, and then freeze them. Then bring the patient back and go with your GnRH. If you have the capacity for 3D, do a 3D before you start. You will see the infiltration of the junction as well. After 3 months of GnRH, given every 28 days, start the GnRH on 21 of the cycle in order to prevent the flare effect of the GnRH use on the 21 of the cycle, and repeat every 28 days for 3 cycles. At the end of 3 cycles, go and do a 3D to see that there's clear demarcation of the junction as well. It's helpful. If it's not demarcated, advise the patient. You need to take 1 or 2 more so we can scan. And then once you're done with that, very nicely, take the patient in and do an embryo transfer. That's it.
Okay, sir. Gift Thomas is asking, what is your take on combination of letrozole and progesterone in management of adenomyosis?
Well, to be honest, it's neither here nor there. It's one of the medications that is postulated, you know, aromatase inhibitors. Are they effective? I do not know. So it actually is something in the days when we were residents, says it's mentioned to be discarded or something like that. So it's not of significant value, but it's a tool.
Okay. So we have 2 last questions to go. Abdul Malik is asking, are there certain foods recommended for patients with adenomyosis And what type of food should be avoided in such patients?
I do not know. But, you know, my answer to any question on food in Africa is that what food do we eat? Let us be honest. In Africa, this morning, if we take a sample of the food that we all ate this morning, probably we ate rice, or we ate bread, or we ate yam. If we take a sample of the food we are going to eat this evening, probably is swallow or is a yam or something. Tomorrow, is it going to change? That's what we are going to do. We don't have food variety. So why do we keep talking about what food are we going to eat in Africa? So I do not know the answer to that question.
Okay, thank you, sir. Lastly, Gladys is asking if a nulliparous woman has been diagnosed of frozen pelvis and she's desirous of having a child or a baby, what fertility option can be offered to her?
The first point is to understand that what is frozen pelvis. You know, that understanding is important. As a young consultant, I once called the senior surgeon to join me at surgery. And when we opened up, he just laughed. He said, "This is what gynecologists call frozen pelvis." he laughed. So, you know, those things are neither, you know, the first point is, what is the cause of the frozen pelvis? If it's endometriosis, then we have to follow through with all the things that we have discussed today. If it is previous surgery, multiple surgical exposure, that's a different issue altogether. So the patient seek clarification on what is my diagnosis. Diagnosis is therapy. If you know what the problem is, it's 50% solved. So she doesn't know what the problem is. She needs to know what the problem is before we start talking about fertility options.
Thank you very much, sir. We appreciate it. Can we please give Dr. Kingsley our best emoji in the house, please? Thank you so much. We appreciate you. Finally, before we wrap up, I would like to once again remind us of our forthcoming 15th edition of AFRH Annual International Conference, scheduled for September 24th to 26th, 2025, at the prestigious Lagos Oriental Hotel, Lekki Epe Expressway in Victoria Island, Lagos. And the call for abstract submission for this year's conference is ongoing. The submission deadline is August 15th, 2025. Please note that no further extension will be granted after August 15, 2025. The conference registration and payment are required for your abstracts to be considered. Kindly refer to the conference flyer for all the details. The link provided will guide you to more information. And then, of course, I'm pleased to emphasize the fact that 100,000 cash prize, courtesy of Mrs. Bobo Kayode Memorial Foundation, will be awarded to the best abstract presenter during the conference. Don't miss this chance to showcase your research and insight. Submit your abstract today. Kindly follow AFRH on all our social media handles as displayed on the screen. Now, on behalf of AFRH, I sincerely appreciate everyone for making time to attend our bi-weekly webinar series. Please join us again for our next edition, scheduled for August 27th, 2025. Till then, I remain Inikli Uja Samuel. Thank you, and over to you, Ma.
Thank you so much. Thank you, Dr. Agholor. Thank you, Inipi. And thank you to our audience. We had a fantastic turnout. At some point, I was looking at about over 80 attendees attending this webinar today, which is a very, very good turnout. We do appreciate Dr. Agholor for giving us yet another very, very educative and interesting discussion on this topic that haunts everybody in this space. I would like to recognize the chair of the training committee. He's in the house today, Dr. Lateef Akinola. Thanks for attending. If you want to say a word before we wrap up the webinar for tonight.
Yeah, I want to thank you, Dr. Kingsley Agholor. I know that the lecture is going to be fantastic because he always does his own work very well before it comes. So is giving us one of the best, and we must appreciate him for that. And I'm happy that a lot of us turn out to listen to him. It is quite very interesting that we got that distinction between adenomyosis and endometriosis. And we all know now they are a spectrum, but there are subtle differences in the phenotypic appearance and genetic dispositions. However, they all come from the fact that the endometrium in the endometrial cavity travel to somewhere that is not supposed to be, or whether it's a mutagenesis at the original site, it's not correctly been proven. But we know that they are related, but there are some subtle differences. And if you see one, make sure you look very well for the other ones. It is also very, very, very important because they are always linked together. And at the other spectrum of it is also fibroid. So it's been found that fibroid is always associated with endometriosis in at least over 50%. So if you see one, always make sure you look for the others so that you can give the patient holistic management of our condition. The only two remarks I want to make concerning diet, it's been advisable that if you have endometriosis, diet also has or adenomyosis or endometrioma, diet also has a very strong correlation with this. If you go on the correct diet, you get the best outcome at the end of it. Endometriosis, adenomyosis, or endometrioma, we all know they have this inherent inflammatory process in them. And what is causing the inflammation? If you can get a diet that will reduce such inflammatory process, your endometriosis will do well. And what are the anti-inflammatory drugs that we have? Go on low carbohydrate diet, and then use a lot of antioxidants that will remove those oxygen species that will cause inflammation. So go on fruits, avoid excess carbohydrates, go on supplements that will reduce the anti-inflammatory, that will reduce the inflammation in the system. And then concerning letrozole, we don't use letrozole if the patient is going to be on IVF. Letrozole is good. It's an aromatase inhibitors. It works against the endometriosis because the endometriosis is mainly dependent on estrogen. It's, it reduces the amount of estrogen in the system. But at the same time, you need estrogen for your endometrial growth. So it's like you are killing one and then or you are trying to kill one and then you are killing the other one as well. So in as much as you are going to get less estrogen in the system, estrogen is also very important for your endometrial growth. So if you reduce estrogen, it affects the endometrial growth. It's the same like you use clomiphene citrate. Clomiphene citrate also have the similar effect on the endometrium. I used to give letrozole in the past, or Clomid in the past, for somebody. I mean, it's not only me, it's the system before, that you have a very poor patient that responds to stimulation. You are giving them the maximum. At that time, we go to the maximum dose of FSH or FSH plus LH of 600 international units. And then we also give them either Clomid or letrozole. Now we know that if you are going to give more than 300, you are just wasting your money. It's not going to give you anything more than that. And then, so we cut it down from 600 international units to 300. Maximum of 300 is what we are advised to give. And then we now see that letrozole and clomiphene that we add to it, have a detrimental effect on the endometrial growth. So that is why it is not advisable if she's going to go on IVF or she's going to have IVF treatments. Letrozole or Clomid are not indicated. So it's either you are going to do what Dr. Agholor advised, do a freeze-all, give her some GnRH analog treatment until all the conditions and anti-inflammatory drugs until all the conditions revert back to normal. And then, in most cases, they do well. It is not that somebody with endometriosis, endometrioma, or adenomyosis cannot get pregnant. If we can manage the treatment very well, they can get pregnant, even though their chances are less better, a less reduced or lesser than what obtains if somebody doesn't have those kind of things. But science is proving, and then there is development going on to improve their own outcome as well. Thank you so much, my moderators. Thank you, Dr. Agholor. And I believe Dr. Agholor will give us a manuscript, extended manuscripts to put in our upcoming textbook, please. It is important. Thank you, thank you, thank you.
That one is a given.
Thank you.
That one is a given. It's not hope. It's for sure.
I can't thank you more than enough. And then we also take the opportunity to invite Dr. Agholor to our podcast series to give us a good coaching on the work of ultrasound, how we can manage the effect of ultrasound scan in the management of endometriosis, adenomyosis, and endometrioma in future. Thank you there.
Thank you. I look forward to that.
Thank you. So much, and for the benefit of some of our listeners, Dr. Agholor is going to be at the pre-congress for the upcoming AFRH conference, doing what he knows how to do best. So please join us at the ultrasound training at the pre-congress for the AFRH conference. All right, people, and it's a wrap, and it's 5:28, just perfectly timed. Dr. Agholor, you're always appreciated. Thank you very much, and have a wonderful evening.
Thank you so much. I appreciate it. Bye.